If you don't control your focus, your mind will remain distracted by countless external stimuli, which so-called life-saving test after your 70th birthday could launch you into a cycle of invasive procedures you never needed. And what new research shows that skipping certain routine screens might actually give you more healthy years instead of fewer. Stay with us, because we're about to uncover 7 everyday checkups that sound protective yet increasingly prove hazardous once you hit 70. You'll hear the eye-opening statistics clinics rarely mention, learn the red flag words to watch before you sign after any consent form. Right at the end, get a 3-step decision compass to help you walk into every doctor's visit calm, confident, and firmly in control of your own health. The overdiagnosis trap. Overdiagnosis sounds harmless, just more information, right? In reality, it is a trap that quietly turns healthy seniors into perpetual patients. Medical journals define it as the detection of a disease that would never have caused symptoms or shortened life during a person's remaining years. The older we get, the steeper that trap becomes because background rates of slow-growing tumors, minor artery blockages, and borderline lab numbers all climb with age, while the time left for those findings to matter shrinks. Picture Mr. Smith, 72, who felt perfectly well until an executive clinic offered a gold package scan. A shadow on his lung led to a biopsy that punctured his pleura, putting him in hospital for a week. The nodule turned out to be benign scarring, yet the cascade had already drained his savings and confidence. Stories like his illustrate why some researchers estimate that up to 1/3 of cancers detected by screening in older adults pose zero threat, yet trigger surgeries, radiation, or lifelong medication. Why does the trap tighten after 70? First, life expectancy math. A test that prevents death 10 years down the line offers little benefit to someone whose other conditions limit their horizon to 6 or 7 years. Second, competing risks. Anti-hormone drugs prescribed just in case may weaken bones, while aggressive cardiac interventions can cause kidney injury or stroke, harms that matter today, not decades later. Third, each abnormal result unleashes follow-up scans, referrals, and procedures with their own dangers. Economists call this a diagnostic cascade. Geriatricians call it a spiral that erodes independence. The psychological toll is just as real. Being relabeled from healthy to patient increases anxiety, fuels insomnia, and, even when treatment is unnecessary, makes insurers flag you as high risk. A 2024 meta-analysis showed that older adults given a serious-sounding diagnosis they did not understand were twice as likely to reduce social activities within 6 months, accelerating frailty. Most heartbreaking is time lost, hours in waiting rooms instead of with grandchildren. Yet the system keeps nudging seniors toward overdiagnosis because every new imaging modality promises sharper images. Every laboratory panel advertises more markers, and fee-for-service models still reward volume. Recognizing the trap is therefore your first act of self-defense. Throughout the rest of this video, we'll examine 7 high-profile tests: bone density scans, PSA, late-life mammograms, stress tests, colonoscopies, whole-body imaging, memory kits, and megapanel blood work, showing exactly when each flips from helpful to harmful and what safer alternatives exist. Keep listening, not in fear but in curiosity, because once you grasp how overdiagnosis works, you can start asking the single most powerful question in medicine. Will this result, even if abnormal, change what we do in a way that improves how I feel or how long I live? If the honest answer is probably not, you just stepped clear of the trap. Bone density scans. When numbers lie. Bone density testing, DEXA, became popular in the 1990s, and many clinics still auto-schedule a repeat scan every 2 years after age 65. But evidence shows those intervals are often far too short. A landmark New England Journal of Medicine cohort followed 4,957 women for 15 years. Among those with mild osteopenia at age 70, it took more than 15 years for even 10% to progress to true osteoporosis, suggesting that most could wait a decade before the next scan. Why, then, do so many elders end up on the scanning treadmill? Partly because the machine prints an easy-to-grasp T-score. Anything below -1.0 earns the label osteopenia, a word that sounds medical and alarming even though it often predicts no fractures. Marketing fills the gap, brochures warn that 1 in 2 women will break a bone, omitting that age, falls, and frailty matter more than a single X-ray number. Labeling triggers treatment. Bisphosphonates such as alendronate and zoledronic acid can be life-saving in high-risk osteoporosis. Yet in low-risk osteopenia, they expose patients to jaw osteonecrosis, atypical femur fractures, and severe heartburn without clear benefit. The US FDA has logged thousands of adverse event reports, most in women over 75 who never met criteria for drug therapy in the first place. DEXA scans also create hidden costs. Co-payments, transport, radiation, albeit low, and the anxiety of borderline results that prompt earlier retesting. In focus groups, seniors described feeling pressured to drop hobbies like gardening after being told their T-score was below normal, despite no fracture history. So what makes more sense? Geriatric endocrinologists recommend moving from a numbers-only model to a risk-based one. That means combining age, prior fractures, body mass, balance problems, and certain medications in tools like FRAX before deciding on scanning frequency. For many healthy 70-year-olds with no fracture history and a normal initial DEXA, repeating the test before 80 is unnecessary. Simple, low-tech measures, daily 20-minute walks, chair-rise exercises, and muscle strengthening with light weights reduce fall risk more effectively than chasing marginal changes on another printout. Diet matters, too. Seniors absorb calcium less efficiently, so pairing calcium-rich foods, dark greens, dairy, sesame, with vitamin D from moderate sun exposure or a modest 800 IU daily supplement often outperforms prescription drugs for borderline cases. Balance training programs, Tai Chi, and home hazard checks further cut hip fracture risk. Next time a clinic calls you in for an annual bone test, ask, "What is my absolute fracture risk? What will you do differently with the result?" If the answers are vague, consider deferring the scan. Information is useful only when it changes management in a meaningful way. Otherwise, it is noise masquerading as care. PSA and prostate biopsies. A double-edged sword. For men over 70, PSA screening exemplifies how a well-intentioned test can tip the risk-benefit scale the wrong way. The U.S. Preventive Services Task Force assigns a D grade, recommend against, to routine PSA testing in men 70 years and older, citing minimal survival benefit and significant harms. The PSA, prostate-specific antigen molecule, is not cancer-specific. Elevated levels arise from benign enlargement, infection, even cycling. Yet any rise over an arbitrary threshold often launches a biopsy. Those biopsies are not benign. Infection rates up to 3%, bleeding, urinary retention, and, in some cases, lifelong erectile dysfunction. One multicenter review found 12% of men hospitalized within 30 days of transrectal biopsy were over 75. Complicating matters, autopsy studies reveal that 70% of men in their late 70s harbor microscopic prostate cancers so indolent they never cause trouble. Treating such findings, surgery, radiation, hormone blockade, carries risks of incontinence and bone loss that outweigh any theoretical benefit for men with limited life expectancy or multiple comorbidities. Shared decision-making is therefore crucial. Here is a simple 3-point checklist you can screenshot and bring to your urologist. Life expectancy horizon. Do I have at least 10 to 15 more years during which an aggressive cancer could shorten my life? Competing risks. How would existing conditions, heart failure, COPD, diabetes, influence my ability to tolerate biopsy and treatment? Management pathway. If the PSA is high, am I prepared for active surveillance, or will I feel compelled toward immediate intervention? If the honest answers favor caution, it is reasonable to skip the test. For men still keen on surveillance, ask about the newer prostate health index or MRI-based screening, which can reduce unnecessary biopsies by clarifying which elevated PSAs are worrisome. Equally important is lifestyle. Maintaining a healthy weight, controlling blood pressure, and eating a plant-forward diet rich in cruciferous vegetables may slow prostate tumor growth pathways without side effects. Physical activity also reduces urinary symptoms linked to benign enlargement, indirectly lowering PSA. Remember, choosing not to test is a proactive decision, not neglect. It reflects updated evidence showing that for the average 75-year-old, the pathway from PSA to prolonged survival is narrow, while the corridor of potential harm is wide. The guiding question remains, will this result, even if abnormal, lead to a treatment that helps me live better or longer? If the likelihood is slim, step off the conveyor belt. Mammograms after 70. The gray zone. Breast cancer screening saved lives when introduced to younger age groups, but its value becomes murkier beyond 75. The USPSTF states that evidence is insufficient to judge benefit in women 75 years or older. Research from the Annals of Internal Medicine projects that continuing annual mammograms in the 70 to 85 bracket yields 1 breast cancer death prevented per 1,000 women screened, but also leads to up to 13 overdiagnosed cases and scores of false positive callbacks. Why so many false alarms? Aging breast tissue often shows calcifications and cystic changes that mimic malignancy on X-ray. Each suspicious spot triggers extra imaging or needle biopsy. Around 20% of women over 75 subjected to benign biopsy report lingering anxiety 6 months later. Surgery in older bodies carries higher rates of delirium, wound infection, and cardiac complications. Radiation therapy can stiffen lungs and heart muscle already weakened by decades of wear. Hormonal drugs cause joint pain, raising fall risk. When life expectancy is under 10 years, true for many with multiple chronic illnesses, the survival gain from removing a slow-growing 5 mm tumor becomes mathematically negligible. Still, the decision is personal. Women with a strong family history, BRCA mutation, or who remained exceptionally healthy into their 80s may consider continued screening. The key is weighing absolute benefit, not relative statistics. A practical tool, the ePrognosis Calculator, free online, estimates 10-year mortality based on health status and can guide discussion. If you and your doctor decide to stop mammography, substitute vigilant symptom awareness. Report new lumps, nipple changes, or skin dimpling promptly. Clinical breast exams during other appointments remain low risk and may catch aggressive cancers that present symptomatically. Before we move on, remember one psychological fact. Letting go of long-held screening rituals can feel scary. Reframe the choice as clearing time and energy for activities that definitely boost longevity, strength training, social engagement, nutrition. Health is not measured by the number of machines we pass through, but by the vitality we preserve each day. Quick pit stop, health heroes. We're on a mission to hit our very first 1,000 subscribers, and we can't cross that finish line without you. If this video is opening your eyes, smash that subscribe button, give us a big like, and tell us in the comments. Has someone in your family faced tough late-life testing decisions? And while you're there, drop A with your city or country. Let's see just how far this community of smart, empowered seniors and those who love them can stretch. All right, thanks for fueling our dream. Now let's dive back into the content. Cardiac stress tests without symptoms. Cardiologists often order treadmill or nuclear stress tests just to be safe. Yet leading societies list routine testing in asymptomatic elders as low-value care. Choosing wisely explicitly warns against baseline cardiac stress tests in symptom-free patients. Radiation is substantial. A single nuclear perfusion study exposes the body to about 15 MSV, 500 chest X-rays, and accumulates with each repeat. Continuous imaging raises lifetime cancer risk, a concern particularly ill-suited to seniors who may derive negligible survival benefit from detecting minor coronary narrowing. False positive stress ECG changes are common after age 70 due to baseline conduction abnormalities. Once flagged, these patients often undergo coronary angiography. Roughly 1 in 20 angiograms causes contrast-induced kidney injury, and 2% trigger strokes in octogenarians. Worse, an incidental 50% artery stenosis can pressure patients into stent placement, despite multiple trials, courage, ischemia, showing no mortality advantage for stable disease. When is testing sensible? Evidence-based triggers include new chest discomfort, unexplained shortness of breath, or planning high-risk surgery like valve replacement. Otherwise, lifestyle monitoring beat screens track blood pressure, cholesterol, blood sugar, and aerobic capacity. A brisk 6-minute walk test in the clinic hallway often predicts cardiac outcomes better than an expensive isotope scan. If your physician suggests a stress test, Ask 3 questions. Symptom-driven. What specific symptom or risk factor are we clarifying? Actionable thresholds. If mild ischemia appears, will management change beyond what optimal medical therapy already provides? Alternatives. Could coronary calcium scoring or a plain resting ECG offer similar reassurance with lower risk? Walking away without the test may feel uneasy, yet remember, in cardiology, more data can lead to unnecessary stents, lifelong dual antiplatelet therapy, and bleeding complications that quickly erode quality of life. Protect your heart with proven measures: 30 minutes of movement daily, Mediterranean-style eating, stress reduction, instead of radiation-heavy screens that seldom alter destiny. Experts estimate that 1.5 to 2% of all future cancers could stem from medical imaging. Beyond radiation lies the problem of incidentalomas, harmless nodules or cysts discovered in 30 to 40% of scans. Most are benign, yet guidelines force clinicians to chase them with follow-ups, biopsies, or even surgery. A large cohort of elderly trauma patients showed that 1/3 had multiple incidental findings, few of which required treatment. MRI avoids radiation but still reveals incidentalomas, especially in liver, kidney, and spine. The psychological cost, waiting weeks for specialist opinions, can't be overstated. Researchers note heightened anxiety and medical spending persisting for months after a false alarm. Whole-body imaging also normalizes a mindset that health equals nothing abnormal detected, ignoring resilience, function, and joy. If your insurer or employer offers a complimentary scan, pause and ask, what symptom are we investigating? What evidence shows mortality reduction from blanket scanning in my age group? To date, none. A smarter approach pairs targeted imaging with symptom-based triggers. Chronic back pain unresponsive to therapy? Yes, MRI the spine. Persistent blood in urine? A CT urogram makes sense. But scanning an entire healthy body at 75 risks turning harmless age marks into expensive detours. Remember, reassurance comes from strong muscles, clear purpose, and close relationships, things no scanner can deliver. Consider routine function tests instead: timed up and go, grip strength, and mood inventories. These predict disability and mortality better than a cross-sectional picture of organs caught in a moment. Memory screens and fear-based marketing. Nothing frightens seniors more than dementia, and companies know it. Over-the-counter cognitive kits and slick apps promise early detection using word lists or phone-based reaction times. Yet specificity remains poor. Ethicists warn that blood-based Alzheimer biomarkers marketed directly to consumers risk unduly worrying individuals, whose positive result may never convert to disease. A review of digital biomarkers echoed that false positive dementia label strain already thin specialist resources and burden families with stigma. False alarms lead to cascades: expensive PET scans, off-label drugs, dietary supplement stacks. More insidiously, a premature dementia label can affect driving privileges, insurance rates, and personal identity. Longitudinal studies show that seniors who believe they are cognitively declining, even when objective tests disagree, reduce social engagement, worsening actual cognition through isolation. Professional societies currently recommend targeted cognitive assessment when either the patient or an informant notices decline, or when managing conditions known to impair memory, stroke, Parkinson's. For the average healthy septuagenarian, broad population screening has not improved outcomes. Instead, focus on proven protectors: 150 minutes of moderate activity weekly, blood pressure control, hearing aid use for auditory loss, Mediterranean diet richness, and regular social/intellectual engagement, book clubs, language classes, volunteering. These interventions carry negligible downside and robust evidence for preserving cognition. When genuine memory concerns arise, seek a comprehensive evaluation including thyroid, B12, depression screen, rather than a single app score. If marketing still tempts you, apply the decision compass. Purpose: what will I do differently with the result? Probability: how accurate is the test? Payoff: will early detection change therapy that meaningfully extends quality life? Often, honest answers diminish the allure. Megapanel blood tests and vitamin hype. Walk-in labs now advertise 50+, sometimes 100 parameter longevity panels. vitamin D, B12, magnesium, testosterone, C-reactive protein, homocysteine, the list impresses, but few seniors need them all. Vitamin D testing illustrates the frenzy. U.S. orders soared eightfold in 2 decades, yet deficiency treatment rarely altered outcomes besides bone density in select groups. Overtesting has ripple effects. A borderline low testosterone in an 80-year-old may prompt gels that raise prostate and cardiac risk. Mildly elevated B12 can trip searches for leukemia. Each unexpected result spawns referrals and anxiety. Cost is high too. Some panels exceed $1,000, usually out of pocket. Choosing wisely recommends symptom-driven testing. Fatigue? Check thyroid and iron. Frequent bruising? Platelet count. Suspected malabsorption? Then measure vitamins. Otherwise, let diet and routine markers, CBC, metabolic panel, lipid profile guide care. Beware supplement cascades. Seniors already average 5 prescription drugs. Adding high-dose vitamins risks interactions. Calcium plus certain heart meds raises arrhythmia potential. Vitamin K undermines warfarin. High-dose antioxidants may blunt exercise benefits. Consult pharmacists before stacking pills. A pragmatic rule: if a test result will not change management, skip it. Invest savings in quality food, exercise classes, or travel experiences that boost well-being more reliably than chasing perfect lab numbers. Mastering your medical choices. Information overload need not paralyze. It can empower when filtered through a method. Enter the decision compass, distilled from geriatric shared decision frameworks. Purpose: why test? Clarify the clinical question. Example: will this colonoscopy find treatable lesions that threaten me within 10 years? Probability: what are the chances the test is accurate and that a positive leads to benefit? Ask for absolute numbers, not relative. Payoff: if positive, is there an intervention that improves how I feel or how long I live within a time frame that matters? Run every proposed screen through those points. If any leg is weak, rethink. Bring an advocate to appointments and request printed decision aids, tools proven to improve knowledge and satisfaction. Shared decision-making is not about saying no to everything. It is about aligning care with your goals. Cultivate 3 habits to stay in control. Track functional metrics: timed up and go, gait speed, grip strength. They predict longevity better than CT scans or PSA levels. Prioritize preventables: vaccinations, hearing aids, cataract care, simple services that unequivocally enhance life. Guard mental focus. Echoing Shi Heng Yi, channel attention toward internal mastery, mindfulness, purpose, community. So external stimuli, including flashy ads for unnecessary tests, cannot dictate your choices. As we conclude, remember, medicine's greatest gift is not an MRI image. It is the partnership between informed patient and thoughtful clinician. Use the decision compass, ask bold questions, and keep steering your health journey with clarity and confidence. And there you have it, 7 common checkups that can quietly steal more health than they save once you pass 70, plus your brand new decision compass to keep every future test truly useful. If today's insights gave you back a little control over your own health journey, then we'd love your help in spreading the word. Subscribe to the channel so you never miss our next evidence-packed guide. Like this video, every thumbs up tells the algorithm seniors health matters. Comment below, which of these tests surprised you most, and what one question will you ask your doctor at your next appointment? Share this episode with a friend or family member who could use a clearer path through the maze of late-life screening. Remember Shi Heng Yi's wisdom: if you don't control your focus, your mind will remain distracted by countless external stimuli. Take that focus into every medical visit, use your decision compass with confidence, and keep choosing the tests and the life worth living. Thanks for watching, stay curious, and we'll see you in the next video.